Fracture neck of femur is a very common injury, and most of you are going to do an orthopaedic firm, work in A&E, or do a care of the elderly firm. So it'd be really useful for you to understand a bit of the blood supply of the head of the femur, but also the fracture patterns, because combining those two together means you can work out what needs to be done.
So, can you review the anatomy of the proximal femur, in particular the blood supply to the head in the adult? Do note it's different from us older people than you young lot, and particularly any younger siblings you may have. Review the fracture patterns we see in fractures of the proximal femur. A bit of a hint there, think about whether it's just the neck, intertrochanteric, intracapsular or extracapsular. Then combine the knowledge so you can work out what type of fixation you're going to book for your patients when you're booking them onto the trauma list in just a few months' time. Let us look at the proximal femur and its bony landmarks. We have the head, the neck, the greater trochanter and the lesser trochanter. The capsule of the hip joint sits around the base of the neck and goes up to the ilium. The blood supply for the head of the femur comes off branches from the circumflex femoral vessels which sit around the neck. These branches then come off and go supplying the head of the femur, but they're attached to the neck of the femur. If we get fractures through the neck of the femur, that will disrupt the blood supply and you'll get avascular necrosis of the head. If the fracture is more distal and through the trochanters, or certainly through the proximal shaft, that blood supply going along the neck of the femur will be intact and you won't get avascular necrosis of the head.
Essentially those are the ones which are within the capsule, intracapsular, and those which are outside the capsule, extracapsular. And as we've seen from the video, it's all about whether the head's going to survive or not. If there's a subcapital fracture with minimal displacement, the blood supply to the head of the femur is probably intact, and this could be treated by putting some screws through the proximal femur, through the neck, into the head to stabilise it. If, however, there's gross displacement of a subcapital fracture or a transverse cervical fracture, undoubtedly the blood supply will be disrupted and the head of the femur will go on to die with avascular necrosis. In view of this, the head needs to be removed and replaced with another ball joint. This is called a hemiarthroplasty, where the ball part of the joint has been replaced, as you can see in this X-ray. If the fracture is between the trochanters, intertrochanteric or subtrochanteric, the blood supply to the head and neck of the femur is preserved. This can be treated with a dynamic hip screw, as seen in the X-ray. It's dynamic because the long screw going to the head can back out of the plate and shorten so it doesn't end up inside the pelvis. So hopefully now you can understand the decision-making process as to what type of fixation a fracture neck of femur is going to require, and you can ensure the theatre staff have got the right equipment to fix that fracture to get your patients back on their feet as quickly as possible.